Hello, friends. Today I'm back with a new topic. Is it really new? In fact, this is the most commonly talked topic all over the world. I myself have given more than 60 lectures out of my 600 odd lectures on different aspects of PCOS under different headings. Maybe controversies in PCOS, adolescent PCOS, beyond adolescent PCOS, and so on and so forth. In fact, sometimes when you hear so much and so many times about this, you feel a little bit overwhelmed or confused and things like that. So today I thought let me clarify all the points that I have gathered over a period of time. And as far as the topic is concerned, it also went through many changes, and also the confusions are ever increasing. In this particular aspect, my guru or my teacher for me is actually my daughter. She is the one who gave me a lot of ideas, as well as she clearly explained me some of the concepts. Maybe her grounding was better in KMC Manipal than the grounding that I had during my MBBS days. And she, in fact, helped me to create this presentation. And of course, I have kept on adding to this over a period of time. It was called PCOD, and still many gynecologists call it PCOD. It is wrong to say so because it's not a disease itself. It is actually manifestation of the many underlying problems. So then actually Steen-Leventhal called it Steen-Leventhal syndrome, but then because of its pattern, that is polycystic ovarian pattern, it's called polycystic ovarian syndrome. Syndrome because it has got many manifestations and different manifestations in different people with the same underlying problem, and in the same given person, different problems at different times of her life. So I'm going to discuss various aspects of that under this lecture. And I have more than 120 slides, and I don't think I will be able to finish in 40 minutes. So I have called it part one. Maybe I will go on tomorrow as well as maybe day after tomorrow. I don't want to hurry up. So I will be dealing as much as possible today. Why are we concerned about PCOS? It's the commonest, 1 in 7, that's almost 15%. Most of the diseases are less than 10%. But here you can see it is up to 15% of endocrine disorders in women of reproductive age group. That's big. Of these, 2/3 will have oligo-ovulation, and obviously there will be irregular cycles, but the most distressing problem is infertility. Most have concurrent metabolic disorders which can endanger their life. PCOS as such is not really so dangerous, but the metabolic problems that she can develop much later in life can be detrimental to her. Later in life, they may actually develop type 2 diabetes. That's what I was just telling. Dyslipidemia, hyperlipidemia, in fact, cardiac events, and endometrial carcinoma. So that is exactly why the concern is all about. That's why we must be very careful in telling a young girl that you are having PCOS. In fact, PCOS has become such a common topic even in the layman discussions, and on the TV, many times it comes. And nowadays, the young girls can Google and find out all these things, and they'll get scared that they might develop endometrial cancer, or they will develop cardiac problems or diabetes and things like that. So we have to exercise caution in branding somebody as polycystic ovarian syndrome. I'm going to clarify all these issues in my subsequent slides. Why adolescence is of special concern? Apart from what I said just now, PCOS affects almost 11%, more than 10% of adolescents. Prevalence in adolescents of hirsutism is 18%. When you are young, you want to look beautiful. Of course, not that you don't want to look beautiful when you're grown up, but younger girls in adolescence, they are very, very particular about their looks. And hirsutism is definitely not a thing that is acceptable to any girl. Acne is another very distressing, 30, almost double the hirsutism. So nobody would like to have acne, and that's why even the industry which is selling drugs or selling ointments against this are flourishing like anything. Oligomenorrhea, almost 4 times of this, or double the acne, 80%. That will give rise to distressing situation, in the sense they won't know when they are going to have menses, and their parents, rather mother, is worried a lot, because there is a myth that if the menses is held back, it is bad blood that is held back. They don't know that actually there is no bad blood getting collected inside. It's just the endometrium that is shed, and along with that some blood also will go. But whatever it is, they think that if they don't menstruate regularly, that's a big problem. So that adds additional concern in adolescents. Adolescent PCOS is a complex problem with endocrine, metabolic, and also psychological features. When you have acne, hirsutism, they get depressed. Assessment and management of PCOS in adolescents is inconsistent, with gaps in key evidence-based practice. As far as infertility is concerned, we have actually studied a lot, and other things also is studied a lot, but this adolescent always confuses us with, because even naturally, soon after menarche, few years will be oligo-ovulatory cycles, and irregular cycle is not uncommon. Also, nowadays with the good nutrition and affluent society, most of them will be slightly on the overweight, if not obese. They get confused whether I'm PCOS or not PCOS. So that's why the diagnosis also either underdone or overdone. That's why there is inconsistency in the evidence. So with all that background or a prelude, I will jump into controversies, because this is one of the favorite titles I used to talk about PCOS. PCOS is ridden with controversies, and the more you read, the more confused you are, and more controversies come as you discuss them. So what I'm going to do, I'm going to present 3 slides. The first slide is the controversy or the question. The second, or maximum one more slide, is explanation. And the third slide will be my take. If I simply present the controversy, you will not be happy at the end of the talk. So I have to give my opinion, but in no way I'm saying my opinion is final and the best opinion. I'm presenting after reading, as I have understood, my opinion about it. And also after discussion with my daughter Meghna, we have come to a conclusion. So most of these my takes are actually our take. We have together taken this decision. The first ever controversy, my daughter is always telling that, Daddy, the name is not correct. PCOS is not a correct name. So the first ever controversy is actually, this is a debate between me and my daughter, and she has her own explanation. She says PCO is just a pattern, not a disease in itself. Absolutely, there's a disease in the background, something like the IT people say in the back office or in the back of the computer, calculations are going on or the codes are written. So there is a problem behind, and what is seen in front is a polycystic pattern. That's all. That's not the disease. That's actually effect. It's a reflection of local androgen levels. So androgen is the most important thing which is giving rise to this problem. It's not a cause rather a consequence of chronic anovulation, which in turn is due to hyperandrogenism. So it's a final common pathway for many androgenic states. So androgenic state is not just ovarian, but hyperandrogenism because of adrenal origin also may present like a polycystic pattern. So she suggested a different name and I liked it. Instead of PCOS, call it Picasso, the famous artist. What is Picasso? Polycystic androgenic syndrome of ovary. So here, at least in the definition itself or in the nomenclature itself, we are bringing that the most important part of the PCOS, that is the hyperandrogenism, into picture. I don't know whether you like it or not, but that's both of us agreed we can call it, instead of PCOS, Picasso. The next thing is about its origin. Why a particular girl should have PCOS? Why not everybody? Is it because of the post-birth or the things that happen later in life? Is it environment? Is it obesity? Is it overeating which is causing the problem? Or is the obesity is a effect of PCOS? A lot of controversies. The animal studies, that is in utero exposure to increased fetal testosterone, along with hyperglycemia and hyperinsulinemia, determines PCOS phenotype in adulthood. So probably, if you extrapolate this to humans, the mothers of GDM, with GDM, their fetuses, they will have free supply of the glucose from the mother. As a result, their pancreas will secrete insulin. There will be fetal hyperinsulinemia and fetal obesity. And that may later in life. Now, we all know the Barker hypothesis, which is a different one, where if you have a FGR, later in life, you can develop all sorts of metabolic problems. So it is somewhat like that, in utero origins of the adult problems. So what is called fetal origin of adult disease suggests that FGR is a strong predictive factor for the development of various metabolic diseases later in life. And definitely PCOS is one of them. I will soon explain to you why it is mostly a metabolic disorder as much as it is a hypothalamo-pituitary ovarian problem. We don't know whether egg came first or hen came first. It's such a situation here. Whether it's a metabolic disorder which is giving rise to the hypothalamo-pituitary ovarian problem or the other way around. We will examine that. What is my opinion? Of course, my opinion is that definitely most of the problems that we have in later in life have definitely got an intrauterine origin, and PCOS is not different. Which is the best criteria? That's the biggest controversy. Again, me and my daughter used to discuss this and debate this. We are nobody in front of the big Amsterdam, rather Rotterdam criteria and all those things. But let's examine them. ISHRE, such a big, what do you call, association. ASRM, Rotterdam, 2003, revised in 2018. They all have said 2 out of 3. Now let us look at it. What are the 2 out of 3? Either oligo or anovulation, 1. PCO pattern on ultrasound, 2. Clinical and or biochemical evidence of hyperandrogenism, number 3. Now, what is the controversy here? They have said 2 out of 3. Suppose we just take these 2 as the criteria, oligoanovulation and PCO pattern. Don't you think both of them are same? Or in other words, the PCO pattern is because of oligoanovulation and you are leaving behind the most important thing, that is hyperandrogenism, either clinical or biochemical. That's why we felt that there is need to examine this particular criteria. Whereas this androgen excess and PCOS society has got a better definition according to us, which came up in 2006 and still holding. hyperandrogenism is mandatory for the diagnosis. So they are not saying, select 2 out of 3 or whatever it is, fastest finger first and things like that. So they are very clear. Hyperandrogenism is a must to diagnose PCOS. Of course, Rotterdam and ASRM and ISHRE, they also talk about clinical and biochemical hyperandrogenism, but since they have given us a choice to select 2 out of 3, we felt somebody may leave behind hyperandrogenism, which is the most important part, whether it is cause or effect or altogether, that has been left behind. So think about it. Also, there are some loose ends in ISHRE 2018 guidelines, which is the latest guideline that we are talking about, because after that there were 2 COVID years. Not much has come after that. So the reason was which criteria, the Rotterdam criteria increased the prevalence as much as 50% due to diagnostic switch from androgen excess to ovarian morphology. That's exactly what me and my daughter were talking before 2018, because this particular presentation I did when she was doing PG sometime in 2014-15. Later I added all these things. That time itself she was telling this is a problem, and now Rotterdam criteria is being questioned even in ISHRE. So in the first slide, if you remember, the percentage of PCOS I said is 15%, 1-5. This criteria, which is now neglecting, or rather making people, you don't worry about hyperandrogenism, just look at the PCO pattern. Look at that. The prevalence increases to 50%. And another problem is, if you do an ultrasound in any adolescent girl, or even any lady for that matter, there will be always some antral follicles, which are sometimes big or small. But then, if you do the ultrasound, if you are a gynecologist and if you are aware of these things, you will not misinterpret that. But if you send the person to a radiologist or an ultrasoundologist who is not so much well versed with the PCOS or gynecology as such, he will simply put it as polycystic pattern. For him, antral follicle and follicles, everything is same, him or her. So then the person gets a wrong diagnosis of PCOS. That's what I mean. Morphological threshold was raised to overcome this problem, from 12 follicles to 20 follicles each side. But even then, innocent radiologist, I should say, instead of calling him an ignorant radiologist. So they may see sometimes 20 follicles, antral follicles maybe sometimes, and then they will wrongly call it as a polycystic ovary. Ultrasound, that's why, is not necessary in subjects with hyperandrogenism and ovulatory dysfunction. Now, do you see almost like a U-turn? That is, ultrasound, if you do, everybody will look like a PCOS. But then if you estimate androgen in them, not everybody will have hyperandrogenism, and not everybody will have ovulatory dysfunction. So that is the ISHRE meeting PCO guidelines, June 2019. After that ISHRE guidelines, they have discussed this in length. The recent thoughts, they have not come as a concrete guidelines yet. In adolescents, both oligoanovulation and hyperandrogenism are required. That's the correction they have made, which we thought long back. You cannot get rid of this hyperandrogenism. You cannot just diagnose based only on oligoanovulation and PCO pattern. So this is what they have clearly told in 2019 June. Ultrasound not recommended for diagnosis because you will overdiagnose things. Explore potential of AMH levels to guide diagnosis. Of course, AMH also has got its own problems because it varies from the lab to lab, and then interpretation becomes so difficult. That's why they are simply written explore potential of AMH levels to guide the diagnosis. So what is my take or our take? 2 out of 3 makes hyperandrogenism not mandatory to diagnose if one chooses the first 2, which I encircled in the red, oligoanovulation and PCO pattern. Insulin resistance is not addressed at all. which is coming up in my subsequent slide as a big thing. They have not touched that at all. So I go with AE, androgen excess, and PCOS Society, which told in way back in 2006 that hyperandrogenism is mandatory for diagnosis. So I hope I'm very clear. You may have PCO pattern, you may have oligo ovulation, and you may have amenorrhea or oligomenorrhea, all that is there, or hirsutism, obesity, all that is there. Hirsutism is already a clinical evidence of hyperandrogenism. But if you have this in your mind, you will not overdiagnose or miss a case of PCOS. So I'll go to the next. Before that, ultrasound is not necessary, especially in adolescents, because adolescents may have sometimes ovary looking like a polycystic ovary. So don't subject them for an unnecessary ultrasound just because they say I'm having irregular cycles and I'm looking a little bit plump or overweight. Everybody is not. And another biggest problem among the parents is that hypertrichosis is confused for hirsutism. I want to make it very clear right here. Hirsutism is male type of hair distribution on the upper lip, on the chin, and on the chest and other things. But many young girls may have a lot of hair on their hand, on their legs and other things. That is not hirsutism. That is hypertrichosis only. That can be familial. And in certain areas, it is very common. In South India and where we practice in Manipal, I have seen many of the girls having this. So that is not hirsutism. So that is what I want to clarify, everybody. We have to be very, very careful because it has got a far-reaching effect. As I told you right in the beginning, if you just brand her a young girl as PCOS, she is going to really get worried. She will immediately Google out and in Google, Google University, WhatsApp University, there's a lot of misconceptions and miscommunications, and they, without knowing much about science, they can misinterpret everything and they'll be worried. Next thing, that's what I promised you in the previous slide. What is actually responsible for an ovulation there? Where is the egg? Where is the hen? Who is first? There are two schools of thought here. Again, nothing straightforward, it's controversial. One school says it is a metabolic disorder to start with, and that's exactly why we said this has never been addressed in any of the definitions or in the criteria. The metabolic problem is never thought about. Only pattern, anovulation, and hyperandrogenism is talked about, but nothing about metabolic disorder. But that actually is one of the actual causes. Focus here is on insulin resistance and obesity. The other school of thought says it's a reproductive disorders entirely to do with the HPO axis, and it is related to hormones of reproduction, what they call HPO dyssynchrony. Steady state of gonadotropins and sex steroids is the cause of it, and there is local ovarian hyperandrogenism. So let us first look at the metabolic disorder, that is hyperinsulinemia, giving rise to hyperandrogenism, rather than HPO axis giving rise to hyperandrogenism. So when there is insulin receptor dysfunction, this could be genetic. This could have the intrauterine origins. The pancreas will secrete insulin, increased insulin, something like in type 2 diabetes. There is hyperinsulinemia. This hyperinsulinemia will act on the liver to reduce the SHBG, steroid hormone binding globulins. As a result, there will be increased androgen. So this is one pathway. The hyperinsulinemia will also act on the HPO axis. So that's why I'm saying whether HPO axis is first or whether metabolic disorder is first. You look at this slide and then decide yourself. So we know that hypothalamus will secrete GnRH and it will stimulate the pituitary to produce FSH and LH. But hyperinsulinemia will influence the pituitary to secrete more of LH rather than FSH. That's why what we learned in our undergraduate days, there is a alteration in the ratio FSH to LH will be 1:3. So that is because of probably hyperinsulinemia, which is influencing the pituitary to be in favor of LH. Now, the LH usually acts on the stroma. Insulin also comes there and influences this stroma and tells theca cells to produce more androgen. See, LH itself is telling stroma to produce androgens. There is excess LH. In addition to that, insulin will also influence the stroma to produce more androgens. So double whammy. Then FSH anyway will stimulate the follicles to produce the granular cells, estrogen through granular cells. But then this hyperinsulinemia will influence the follicles also. They will decrease the aromatization of androgens by granular cells. So whatever it is, it will not allow estrogen to come into picture. So the aromatization is also stopped and androgen will remain androgen. That's not all. The hyperinsulinemia will also influence adrenals and there is increased DHEA. What is the net result? There is increased androgen all the way. One is because of reduced SHBG, free androgen is increased. Second one is both theca cells, overproduction, granular cells, stopped aromatization, androgen excess. Adrenals, increased DHEA. Everywhere there is hyperandrogenism. And hyperandrogenism is the hallmark of PCOS. Now let's go to the second school of thought, which says there is a HPO axis dysynchrony. This is the picture which you should be able to draw even in the dead of the night. 2 o'clock, if somebody wakes you up, PGs, you should be able to draw this. And for this, you should know menstrual cycle properly. Remember other day when I was talking about primary amenorrhea, secondary amenorrhea, I was telling gynecology is nothing but menstrual cycle is nothing but gynecology. You should know this in your RBC level. That is initially what happens. There will be both decrease of estrogen as well as progesterone. As a result, there is a positive feedback. That's why FSH comes. As FSH comes, follicles are stimulated and estrogen comes, it will stimulate the endometrium. And as the estrogen increases, there's a negative feedback and FSH comes down, LH will go up. So as the LH goes up, then there will be ovulation and then corpus luteum will be stimulated by that LH and progesterone is secreted. So this I call usually dancing of the hormones. This is normal. But in PCOS, what happens? There is persistent anovulation. As a result, as you can see here, there is LH at a steady high level, FSH at a steady low level, and estradiol is low all the time. Progesterone is also not so much because there's not a proper corpus luteum. So where is the dance now? This is called the hormonal side of the PCOS, steady state, HPO dysynchrony. So what is my take? It's a mixture of both. In some, the metabolic disorder is taking upper hand. In some, the HPO dysynchrony is taking upper hand. But in all, there is some amount of both. So what are the phenotypes? The characteristics are usually hyperandrogenism, chronic anovulation, because of that PCO pattern, then prevalence I talk about, and long-term risk. A frank PCOS, what we call, obviously there will be all of them, hyperandrogenism plus, chronic anovulation plus, PCO pattern plus, and its prevalence is almost 70%. This is the most prevalent type of PCOS, and long-term risks are very common in this type of PCOS, which is called frank PCOS. Then there is something called classic PCOS, where again, all the three are present, may not be so much, but then the prevalence is almost like 7 to 40%. If you just reverse the numbers, if you can see there, the 0, if you take away from the 7, it becomes 7% and 40% this side. Again, this also will have long-term risk factors. Then there is something called ovulatory PCOS, which is very confusing to us. We always thought that PCOS means anovulation. But here, the girl or lady may have hyperandrogenism in addition to having ovulation. It may not be very high levels of androgens. That's why some amount of ovulation still happens. And anovulation is absent here. But PCO pattern may be seen because, as I said, because of hyperandrogenism, there is no proper maturity of these cells, and that's our eggs, and that's why you can see still a PCO pattern. Prevalence is fortunately less common, 7 to 20% only. The long-term risk of this particular type of PCOS is not very clear. Then there is a mild variety of PCOS where hyperandrogenism is plus minus, chronic anovulation is plus minus, PCO pattern is there. See, if you see this particular table, in all the 4 columns, PCO pattern is plus, 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 plus. So that is exactly why, if you go by just the pattern, everybody looks like PCO for us. But look at the first row. The hyperandrogenism, if you look at it, it is present always in frank, classic, and sometimes even in ovulatory, whereas in mild cases, it may be plus minus. She may not be actually a case of PCOS in a full-blown way. And again, in this also, the long-term risks are not very well known. So what are the recent thoughts about the phenotypes? PCOS is a single syndrome in which the individual patient, not the phenotype, should be treated. Don't go by the phenotypic pattern. You look the patient as a whole. Then comes the other controversy. Do we need additional criteria in addition to PCO pattern, oligo-ovulation, and androgenism? They proposed many additional criteria, such as you add BMI to this. Yes, it makes sense because most of them are obese. Insulin resistance, you may add, we were talking about, there is no mention about the metabolic disorder at all, or insulin resistance. Again, when you talk about insulin resistance, how to estimate that resistance is a controversy. We used to do fasting insulin and the fasting sugar to fasting insulin ratio, and we said it should be less than 4%. And then a bigger calculation called HOMA, and much bigger calculation called Quickie, and then a simple 75 gram OGTT. We have given up all the above, and we are only now doing 75 OGTT. What is my take on this? Obesity is not essential because we are seeing lean PCOS patients. That's why I said in most of the patients only. I didn't say 100% of the patients. Although obesity does worsen the clinical scenario, universal screening for insulin resistance is not required. You don't have to, though, because there are 2 schools of thought. I said not 100% of them will have metabolic disorder or insulin resistance. Then in whom we should do the screening for insulin resistance, and how should we do it? The indications for testing for insulin resistance, definitely obesity, premature adrenarche. Obviously, there is some amount of insulin there. We saw that how insulin will influence the adrenals. Irregular cycles for more than 2 years post-menarche. Up to 2 years, it is okay. But after that, if it persists, then you have to suspect PCOS and then do this. Androgen levels, when you estimate in a lady with, let's say, hirsutism or whatever, it is more than 150 nanogram per dl. So you have to rule out PCO, because after that, you will start suspecting adrenal tumors and things like that. And what about the way of doing it? 75 gram OGTT is the best method to do this. Not all those fasting insulin, fasting sugar, ratios, HOMA, Quickie, and things like that. What are the recent thoughts about this? And OGTT should be done in all high-risk patients. In others, OGTT may be done, or even a fasting blood sugar be done, or HbA1c also can be done. There's no mention about the insulin estimation. OGTT should also be done once you diagnose these patients, or if you suspect these patients, but they somehow, let's say, escape the full-blown picture of PCOS. Now they get married and they're planning conception. Before conception, we have to do a OGTT. So my retake, or I reiterate, perform 75-gram OGTT in obese and high-risk patients. I will take up one more controversy and then probably I'll stop today's class. Which androgens should be estimated? I have been telling hyperandrogenism. Hyperandrogenism is very important, so estimate this. Which androgen? My colleague, Dr. Jairam, used to always say you have to estimate the adrenal androgens. Let us look at what are they. Ovarian androgens, obviously androstenedione, testosterone, whereas adrenal androgens are androstenedione, same thing, but dehydroepiandrosterone sulfate, DHEAS. All androgens can produce PCO morphology. The PCO morphology will not care where the androgen is coming from. But the recent thoughts are the calculated free testosterone or free androgen index or calculated bioavailable testosterone. The problem here in all of them is high quality assays such as liquid chromatography, mass spectrometry, and extraction through or chromatography immunoassays should be used. That is the problem. You should ask the lab which method they are using. Direct free testosterone assays such as radiometric or enzyme-linked assays preferably should not be used. So it's not which androgen you're estimating, how it is estimated is very important. By now, you must have realized whenever I'm talking about the recent thoughts, the color of the heading changes to yellow background. Androstenedione and dehydroepiandrosterone sulfate DHEAS could be considered if total or free testosterone are not elevated. So Jairam has a point. If you are not testing for free testosterone, however, these provide limited additional information in the diagnosis of PCOS. Though hyperandrogenism is a must, which one you estimate and how you estimate is important, and this will only give to the additional information. If there's clinical evidence, that should be good enough to start treatment. So what's my take? Ovarian androgens are most important to differentiate from other causes of PCO pattern. So you estimate them, and also you can estimate other things. Whichever is higher, then you know whether the cause is just a PCO or it is an adrenal tumor, because adrenal tumor is more serious compared to PCOS. Should we estimate gonadotrophins? When we were undergraduate students, they used to say FSH to LH ratio should be 1:3. But PCO can be eugonadotrophic. PCO with regular cycles have hyperandrogenism with normal LH. LH levels have no relationship with insulin levels. It's high only sometimes in lean PCOS, and it is the cause of hyperandrogenism in them.